This meeting is being recorded.
Mukesh, it's 7:30. I think we can start.
Yeah, sir. Have Dr. Ramesh and Dr. Sumita, have they joined, sir? And this.
I'm here already.
Okay, sir. Okay, sir. Yeah.
Hi, Ramesh.
Hi, how are you?
Good.
Hi, Ramesh.
Hi, Manjula. How are you?
Thanks for coming. Good to see you.
Pleasure. Yeah.
Thanks for making the time.
Yeah. Most welcome.
So I think we will start the session. So hello everyone. I'm Dr. Mukesh Patil. I welcome you all to session 12 of the Learn from Master series hosted by Academic Cell of AGI Hospital. So we are thrilled to have you join us for yet another insightful session where we aim to learn and grow together from some of the finest mind in ophthalmology. And today's topic is 10-step approach to myopia progression. And it is an absolute privilege to introduce our esteemed speaker, Dr. Manjula Jayakumar, a distinguished pediatric ophthalmologist with over 25 years of experience. Ma'am completed her undergraduate training from Government Kiplock Medical College, Chennai in 1994. Followed by she pursued diploma in ophthalmology from prestigious Shankara Nethralaya, Chennai in 1996. Followed by diploma at the National Board in 1997. Ma'am completed pediatric ophthalmology training at Shankara Nethralaya and cleared fellowship in International Council of Ophthalmology training with distinction. Ma'am worked as a consultant in pediatric ophthalmology and strabismus department at Shankara Nethralaya and as a consultant pediatric ophthalmologist at Vasana Eye Care. Currently, ma'am is working as a senior consultant and in charge of pediatric ophthalmology and strabismus at Dr. Agrawal Eye Hospital and Research Center at Chennai. Ma'am is also actively involved in clinical work, research and academic training at Dr. Agrawal Eye Hospital, Chennai. She is also part of DNB faculty and fellowship training program at the institute. And ma'am has various publications in both national and international journals. And she has a keen interest in surgical innovation. She was a past member of Education Committee of Clinical Board at Dr. Agrawal Eye Hospital. So ma'am has received various awards, which includes Best of IGA Award for the year 2020 for a new surgical technique, and followed by a recipient of the Harbinger Award of Clinical Excellence at Watson Eye Center, recipient of the Best Postgraduate Ramakrishnan Endowment Prize, Shankara Nethralaya, and a recipient of the Eye Star Award at the Dr. Agrawal Eye Hospital. So I welcome Dr. Manjula ma'am. And we are also privileged to have an expert group of panels who are joining today. So we have Dr. Rohit Saxena, who is currently professor and in charge of strabismus services at the Dr. RP Center of Ophthalmic Sciences, AIIMS, New Delhi. Sir has more than 22 years of clinical and teaching experience at the AIIMS. And sir has more than 230 index publications in various journals and more than 50 chapters in national and international books. Sir is editor of 3 books on strabismus surgery, including Video Atlas featuring 100 plus minutes and self-narration of the 30 plus complex surgeries. Sir has delivered 25 plus international, delivered talks at 25 plus international conferences and conducted live surgeries. Sir has received 30 plus prestigious awards, which includes Hariman Ovation Award at DOS 2020, Excellence in Strabismus Award at SPOSI 2020, Best of Show Video at AO, Best of Index Publication at SPOSI 2016, and AIIMS Excellence Award at 2018 and 19. So sir was my mentor in AIIMS, and I was very fortunate to learn pediatric ophthalmology under him. So I would request Dr. Neha to introduce our other panels also. Dr. Neha, please. Neha, please unmute. You are mute.
Good evening, everyone. I am Dr. Neha Singh. Our next panelist is Dr. Meenakshi Swaminathan. She currently serves as a consultant ophthalmologist at Capstone Clinical, Chennai, and also a visiting professor at Sri Ramachandra Institute, Chennai. She completed her MS from PGI. Subsequently, she completed residency from Louisville, Kentucky, and fellowship in pediatric ophthalmology from University of Law. Dr. Meenakshi ma'am has been a pioneer in every sense. She led the path in a pediatric ophthalmology education across Southeast Asia through collaboration with ICO and Orbis. She was instrumental in launching India's first low-dose atropine for myopia control. She is a founding member of Myopia Clinic at Shankar Nethralaya. She currently serves as a chairperson of mentoring program subcommittee ophthalmology of foundation. Beyond ophthalmology, she is a trained Carnatic musician, avid bird, food critics, traveler, and a Spanish learner. We welcome you all, ma'am. Thank you for coming us today and giving a time. Our next speaker, our next panelist is Dr. Sumita Agarkar, ma'am, currently a deputy director at pediatric ophthalmology at Shankar Nethralaya. And she pursued her specialized fellowship in pediatric ophthalmology at prestigious Arvind Eye Hospital. She is the Joint Secretary of Strabismus and Pediatric Ophthalmology Society of India. She is the leading ophthalmologist for Orbis REACH project. She is the member of Myopia Consensus Group. Dr. Sumitra ma'am has authored numerous impactful publications in both national and international journals. Thank you, ma'am, for coming up today. Our last panelist is Dr. Ramesh Kekunnaya, sir. He is currently spearheading multiple critical roles at LV Prasad Eye Institute. He is a network director and also a director of a child site, Institute and Technology Innovation. He is the head of prestigious Jesti V. Ramanamma Children Eye Care Center. Dr. Ramesh sir has made a mark on the global stage through his leadership and contribution. He served as the Executive Bureau Director of the World Society of Pediatric Ophthalmology and Strabismus, a fond member of Pediatric Ophthalmology and the Strabismus Network of the India. He is also a council member of esteemed International Strabismological Association. Sir is a prolific researcher with over 150 peer-reviewed publications in leading national and international journals. His dedication has been recognized through multiple prestigious awards, like the Achievement Award from American Academy of Ophthalmology and the Pacific Academy Award, the International Scholar Award and International Education Award, both conquered by American Academy of Ophthalmology. It's a privilege to welcome you here for this session, sir. Now, before starting our session, our next session, I would like to inform about our upcoming session. First session is on 8th January 2025 by Saurabh Padwardhan sir on phacoemulsification simplified. After that, we have next session on 19th Feb on inherited retinal disease cases by Professor Omar Mahro sir. Now I request Dr. Manjula ma'am to please start your session.
Thank you, Neha. I'll be screen sharing now.
Yes.
The presentation is not seen here. Just open it. My video. 1 minute. Should I just go out and come? It is not seen here.
Okay, ma'am.
Just 1 minute.
Okay, ma'am.
Wait. I will minimize and just 1 minute. It was there only. Stop share. Shall I close and I'll come again? Because I'm not able to see my presentation. It was here, but
Ma'am, you can just
no.
can
1
put
minute.
the presentation from the file, like from the folder, and then
No. It was open only. No, we checked it.
yes, ma'am. Yes.
Right now, it's not there. Just 1 minute. I think I have to leave Zoom and come again because I'm not able to see the window. Just 1 minute. I will stop share and go out and come again. Okay? That should be okay?
Yes, ma'am.
1 minute, 1 minute.
In the meantime, we would request Professor Rohit Saxena sir's like approach to myopia, how he like approaches a patient who with myopia, sir.
So I don't think I would like to preempt actually what Manjula would be saying. I'm sure she would be covering everything.
1 minute.
Yeah, so
I'm
I
having a
mean,
problem. Should I just come into Zoom again?
yeah, Manjula, I think you can do that, or else you can mail your presentation to anyone, Mukesh or
Just now it
Neha.
was open. This thing. Just 1
Yeah,
minute.
we saw that. Maybe while you're trying, you can also email it to Mukesh or Neha or someone so that they
Just
can
1
run it
minute, 1
just
minute.
in case you still face problems.
Return to meeting. Okay. I think now I will share. Okay. Got it.
Yes,
I got
you're
it.
on. Great.
Gave me a scare actually. Okay. These are my slides. Okay. Thank you for inviting me. A very warm good evening to all of you. Today I'll be talking on a simplified 10-step approach to myopia progression. Okay, we all know that the world is currently experiencing a myopia boom. But what exactly does myopia mean to our children? Myopia means dependency of spectacles. Therefore, it limits the freedom of a child. And when this child grows into adulthood, it can experience one or more devastating complications of the higher degrees of myopia, be it cataract, glaucoma, retinal detachments, macular degeneration, which will reduce the quality of life on the child and also cause a great socio-economic burden to the society at large. Therefore, it is imperative on our part as pediatric ophthalmologists, to curb the myopia progression. So I will be simplifying my talk into 10 steps. The first step is to identify your patient with the risk of myopia progression. The second step is grade that myopia which exists in your child. Make or incorporate lifestyle changes, which you have to keep reiterating at every stage. That will be your third step. The fourth, weigh all the treatment options at hand. Fifth, we will be studying the pros and cons of pharmaceutical therapy. Sixth will be optical and orthokeratology. Seventh is to assess and document your patient. Eighth, see whether your patient fits into the inclusion criteria. Ninth, select a modality of treatment. One or two modalities of treatment if needed. 10th would be to follow up the patient. So the first thing is to identify your patients. Now we can divide this into two categories. Increased risk of onset, increased risk of progression. Let us first see who are the children who are at increased risk of onset. Parental myopia, where one or both parents can be myopic. If it is one parent, the risk of myopia development is 33% and both parents it doubles to 50%. Refractive error. If the child is more myopic than age normal or progression is worse than 0.75 diopter per year, if they are East Asian ethnicity, they do excess of near work or outdoor time is limited. All these risk factors will increase the risk of onset in a child. What are the risks for increased progression? Onset of myopia in less than 9 years, that is early onset myopia. Again, the presence of parental myopia. Refractive error, which is more myopic than age normal, or progression, which is worse than 0.75 diopter per year. And of course, ethnicity, which is Southeast Asian. Now it's almost like a global phenomenon. I think it is no longer restricted to the Southeast Asian population. Indians are also at equal risk. So this will be your assessment of risk to identify your patient. And once you have identified your child, the next is you have to see what is the type of myopia or the severity of myopia the child is suffering from. Is it a pre-myope? Pre-myope is a low hyperope to a low myope in a 5-year-old child, or a low myope, which is 1 to 3 diopters, moderate less than 6, or very high myope, which is more than 6 up to 12 diopters. We exclude certain categories. One could be pathological myopia because we are looking at purely physiological axial myopia. Children with inherent ocular diseases, children who have syndromes, because all these categories can have myopia other than axial. They can have lenticular, they can have corneal. So many other causes of myopia can be attributed to the minus power. So these have to be excluded from your patient criteria. The third step is to incorporate lifestyle changes. This is one of the most underplayed steps, but it is the most important thing. We already know that if it's an early onset myopia, if the child is less than 9 years, or if both parents, one or both parents is myopic, the progression is going to be faster in the journey of myopia. But at the same time, there are certain pit stops along this journey of myopia, which is going to fuel this journey faster. And those pit stops could be limitation of outdoor time, which can be less than 1 hour. So if you see a child with myopia at high risk, parental myopia and early onset, spending less time outdoors, then you have to counsel them to spend more time in sunshine, more time with play and things like that. The second pit stop is if there is more of near work, which is more than 2 hours of close work, excluding the school work. So again, this has to be emphasized upon as to how amount of hours that they can spend at near work. If you see a child with binocular vision disorders, it could be anything like esophoria, accommodation lag, high AC by ratio. Now, all these things are indicator that the progression is going to be faster. So when you assess your patient and they have these BV disorders, again, you need to treat these BV disorders so that this myopia journey doesn't get accelerated. So these lifestyle changes and looking out for indicators of progression of myopia is very important step in your management of myopia. The fourth step is what are the treatment options available at hand? It could be low dose atropine, myopic defocused glasses, orthokeal lenses, or it could be myopic defocused contact lenses like the MySight, EDOF contact lenses, or even red light therapy. So there are various options at hand, but I'm going to talk on the more relevant options which all of us practice, the first 3 on the top. So the fifth step is I'm going to talk on the pros and cons of pharmacological agents, that is low dose atropine primarily. How does it act? The main thing is low dose atropine is a very, very minute concentration of the regular 1% atropine that we use. So it is not acting on your accommodative pathway. So how does it act? It goes into your vitreous humor and it gets lodged on the M receptors found on the RP cells. it also increases the retinal dopamine levels. Thereby, it changes the scleral remodeling and also increases the choroidal thickness, thereby reducing the axial length progression for myopia. This is the mechanism of action of low-dose atropine. And there are various studies which have proven the efficacy. For example, the ATOM 1, which compared 1% atropine with a placebo. It's a 3-year RCT. ATOM 2, which studied the efficacy of 0.5, 0.1, and 0.01%. It's a 5-year study. The LAMP, which studied the efficacy of slightly better concentrations of 0.05%, 0.025%, and 0.01%. We have the ongoing ATOM 3, which will aim at treating non-myopes and pre-myopes who have high risk of progression with low-dose atropine. But there is one study at the bottom of the table which confronts all these studies which has happened previously, the ATLAS study, which says that they studied about a quarter of the population who have been enrolled in ATOM 1 and ATOM 2 against people who have never been treated with low-dose atropine. They found out at the end of 20 years, the spherical equivalent refraction and axial length progression were almost the same. So this is a total negative thing to all the other previous studies which has happened in the past. So, but still, low-dose atropine is part of everyone's domain in the treatment of myopia progression. So let's see, and it's one of the most easily available. So let's see how is the treatment regimen started with low-dose atropine. So in case you're using 0.01%, now people are also using 0.05%. So I've stuck to the commercially available LDA, 0.01%. You check refraction every 6 months. And if you see that this patient is stable, that is, the progression is less than half a diopter per year, you continue this patient for 2 years on LDA and then stop the treatment for 1 year. In that 1 year of stoppage, if you still find the patient stable, then that's the end of your treatment. But if you find that the child is progressing, you're restarting them with low-dose atropine again up to adolescence. That could be up to 12 or 14 years of age, along with encouraging outdoor activity. But even within that 6 months or 1 year of initial treatment, if you find that your child is a progressor, more than half a diopter per year, you can still stick on 2.01% because it may show more efficacy in the second year of treatment, or you can increase your concentration to a 0.05% atropine, or look at other treatment modalities, a better treatment, or I won't say better. People consider orthokeratology to be a more bracing treatment for myopia progression. Things like that can be taken into hand. And if it is a progressor, you don't stop at 2 years, but you continue treatment up to adolescence. And thereafter, you can either abruptly stop or taper and stop. So this is how low-dose atropine is actually given in clinical practice on our patient profile. Now, let us look at the pros and cons. The pros, easily available, yes. Economically feasible to the parent, yes. It can be used as a primary or adjunct therapy. The range of power which is not covered sometimes by the myopic defocal glasses can also be put on low-dose atropine. And you have fairly large RCTs at hand, the ATOM 1, 2, 3, the LAMP study, proving the efficacy of this low-dose atropine. Cons, it's invasive. You're using a preservative for a long period of time in a child's eye. Compliance to therapy is important. There is a huge risk of rebound on cessation. There can be side effects to therapy like glare, blur, and loss of accommodation rarely. And each formulation of this commercially available LDA has a different preservative. One has a biguanide, one has a stabilized oxychlorocomplex. So is the efficacy really proven, or is it dependable? That's another question mark. And of course, you have this ATLAS study, which has confused all the other RCTs which has come before that. So these are the pros and cons of LDA. So having said that, let us go to the next mechanism of reducing myopic progression, which is your peripheral defocus glasses, myopic defocus glasses. A child with myopia will have the rays of light falling in front of the fovea, and the peripheral rays, the mid-peripheral rays falling behind the retina. Now, when you give them the concave lenses or the minus glasses, this image is focused on the fovea, but this peripheral, so-called peripheral hyperopic defocus, which you see in the mid-periphery, gets accentuated further. And this can act as a stimuli for axial length elongation. So this is the mechanism which has been taught for the eyeball elongation in myopia progression. So we have glasses or optical measures to reduce this peripheral hyperopic defocus. The other mechanism that can happen in a patient with progressive myopia is accommodation lag. Accommodation lag is hyperopic shift at the fovea because of an insufficient accommodative response to a near target. Now, this is again a sign of progression of myopia, and we need to treat this accommodation lag if we do not want a myopia progression. So based on these two principles, we have a lot of optical measures. If you have an accommodative lag, to reduce it, you can use either a bifocal or progressive addition lenses. If there is a peripheral hyperopic defocus, which is very significant, then the first lenses which came into the market are the peripheral retinal defocus spectacles, which has a clear central zone to correct your myopia, and aspheric plus add in the periphery to reduce your hyperopic defocus. Of course, you have the newer gens in the market, like the defocus incorporated multiple segments, which has a single power lenslet of plus 3.5 in the mid-periphery, or the HALT, which has concentric rings, but of various powers in each ring, so it's a volume of defocus, or the diffusion technology, which reduces the contrast between two adjacent cones, which can also be a driving stimuli for axial length elongation. So we will stick to the commercially available so-called lenses, defocus lenses, which we have in market first. And I've just put it in any order. You can choose any of these things. For example, the Zeiss as the cylindrical elements like this. You have a soft design with a lesser add in the mid-periphery for the older children, and you have a stronger design which has got a more add for the younger children. And this is how the Zeiss defocus, the same principle, it converts the peripheral hyperopic defocus into a myopic defocus. The next is the DIMS, which you have from Hoya, and in the mid-periphery, you have a honeycomb of plus 3.5 diopter single plus power defocus. So this is going to cause a linear defocus in the mid-periphery, linear myopic defocus. Whereas the HALT will have elements of different plus powers. And so this is going to cause a volume of defocus in your mid-periphery. So all these are almost similar in their efficacy. So it all depends on what you want to choose. There is no thing as this is better than that, whatever you're comfortable with. So what are the pros and cons of these defocus glasses? They are non-invasive, and the biggest advantage is the rebound is almost nil. We know that LDA has got rebound, but defocus glasses, the rebound is not so much. Easy adaptation. You can use it as primary or adjunct therapy. But the cons are it's a relatively more expensive kind of therapy, which, the vast majority of population may not fit into that range of expenditure. The range of power is limited. And of course, said and done, the child has to, adapt during that period to overcome the mesh-like effect these glasses will produce until the brain adjusts to these defocus rings. So these are the pros and cons with these glasses. Of course, we have orthokeratology. It's being used extensively in far other countries than our own. They are RGP lenses meant for overnight use. Of course, they'll flatten the central retina to correct your myopic power. And there is a myopic defocus, so they steepen the peripheral cornea. The same thing what your glasses do, the contact lens does, but it causes a spectacle-free day vision. And of course, it reduces the peripheral hyperopic defocus by causing a peripheral myopic defocus. It's a very effective method of retarding myopic progression, and up to -10 diopter sphere can be corrected with the orthokeratology lenses. The pros is you don't have to make your child wear any form of glass or anything in the daytime. It's a spectacle-free day vision. It's an effective therapy for myopic progression, but you need meticulous fitting, proper follow-up, cost is prohibitive. There is always risk of infectious keratitis, dropout rate is there, and rebound is also as high as what you see with low-dose atropine. So these are the pros and cons with the different kind of lenses which we have in market. Now, the seventh step is assess your patient. This is the most important step because we should not rush into treatment. This is the most important thing that I would like to say. So do a good cycloplegic wet retinoscopy to evaluate your baseline myopia. Use the same cycloplegic agent every time you see the child. Give enough time for the child to get dilated and then assess your child, because you don't want all these pseudomyopic component, because most of us use the AR and then the child, there is a pseudomyopic component if they are not adequately cycloplegic. You also need to call back the child again to do a dynamic retinoscopy. Why? You want to assess the accommodative lag. The presence of an accommodative lag is going to increase your myopic progression. Assess the muscle balance for esophoria. Again, esophoria is a red flag for myopic progression. High AC by A ratio is the child suffering. Again, a risk factor for myopic progression. The child can have other forms of muscle imbalance like an exophoria or IBS. And these things are important because we know how closely myopia and IDS are interrelated. And you also, if possible, can do a peripheral hyperopic defocus assessment with an open field AR. See, this is open, and you can use targets for the child to fixate both in the horizontal and vertical meridian, 20, 30, and 40 degrees of your fixation to assess and get an overall idea of the peripheral hyperopic defocus. Okay, the seventh step is to document. What would you document? The main thing that you would document is axial length. And there are various platforms. Of course, on top of the table is the Myopia Master, because it it subdivides your myopia and how much is the axial component, how much is your corneal component, and how much is your lenticular component. So this is a very easy way of looking at axial myopia per se. And of course, we have the LensStar myopia platform, which is going to plot your patient's myopia profile with age-related normal. And also, it is going to give the various therapeutic options, what it would be. So this would be an easy form of discussion with the parent as to what treatment modality you can offer. And of course, when you see that it's a corneal myopia, sometimes you may need corneal mapping also in the form of pentacam or OpScan, because you may need to rule out ectatic corneal disorders like keratoconus. Not in all cases, but if you suspect. Okay, the eighth step is, which patient are you going to involve? Are you going to treat every myope, or are you going to have certain special inclusion criteria? Because everything should have a scientific rationale or thinking behind treatment. So progression, documented progression more than 0.75 diopter per year. That means you should have seen the child in 2 consecutive visits at 6 monthly interval. It should be purely axial myopia, because all these regimens or treatment modalities have been tried. or advocated for pure axial myopia, or you can include axial myopia with low myopic astigmatism. No hereditary retinopathies. Age is between 6 to 14 years. No significant anisometropia or amblyopia. You can include children less than 6 years if they are pre-myopes with high risk. So these would be your inclusion criteria for starting your myopic anti-progression measures. And then the ninth step is, what is your selection? Because you have 3 in hand. I'm only talking about 3 because the rest are all very minimally, or few people may be using it. You have low dose atropine, you have your defocus glasses, you have your ortho K lenses. So which one are you going to? If it's a pre-myope, low dose atropine is more than enough. If it's a mild, moderate, high myopia, you're not able to assess the peripheral hyperopic defocus, you can get away by giving low dose atropine. But if you have more insights into your patient, like you have assessed the peripheral hyperopic defocus and you find it is significant, you can, even if it's, you can use peripheral defocus glasses for all 3 grades of myopia, mild, moderate, and high. And orthokeratology, it's purely, so the what treatment modality, if your patient wants spectacle-free vision, what is your patient's need? All 3 modalities of treatment has to be discussed with pros and cons with your patient and taking into consideration affordability, follow-up, and things like that. You have to decide on whichever treatment modality you want to do. But of course, look at red flags. Don't start off without red flags. Positive family history, early onset of myopia, moderate to high myopia, even at presentation, progression of myopia documented, sedentary lifestyle of the child, and progression. If there is progression with one therapy, you may need to add another therapy or change the therapy. So all these things have to be at the back of mind when you're selecting your treatment of modality and also when you're following up the patient. How long is the question? If you look at age-wise distribution, the greatest axial length progression will happen in less than 10 years. It's 0.3 millimeters or more per year. And after 10 years, the progression is only 0.2 millimeters per year. So you need to treat these children at least minimum up to 12 years of age. Sometimes you may have to extend the treatment up to 14 years of age. It is case by case basis. Treatment is definitely needed before the teenage years, up to 10, and you may have to spill over the treatment even longer. So that 2 years of treatment is not a very strict kind of a thing. You may extend treatment even up to 14 years in most cases. And if you look at efficacy comparison, if there is no treatment at all, less than 9 years, it is going to be 1 diopter change per year. But when you use a therapy, it is going to be lesser than 0.5 diopters. Okay? And 9 to 11 years, it is 0.75 diopters per year. And when you use a therapy, it is 0.37. And in 12 to 16 years, it's half a diopter. And when you use a therapy, it is quarter diopter. So what is it doing? Be it your defocus glasses, be it your low dose atropine, be it your defocus contact lenses, or be it your ortho K lenses, all these are actually reducing your progression by 50%. They're almost equal on par on table. If you do not give any therapy, this is your progression change every year. And if you give it, it's going to be reduced by 50%. So I've come to the last bit of my presentation. So you have to actually document progression, select your patient, incorporate lifestyle changes at every point of time, start a treatment modality if there are red flags, whichever is apt for your patient, taking into consultation the parents into consideration. And then we look at a world which will have freedom from spectacles or at least minimal power so that our children can have happy childhood years with movement and joy and progress into healthy adults with less complications in the future. Thank you very much for your patient hearing. I'll stop my share.
Thank you very much, ma'am, for such a wonderful presentation. it will definitely help us to manage myopia progression better than before. So I will request our experts in panel to give their valuable inputs, and in between we'll take questions also, which was asked by the audience. So please, Dr. Rohit, Dr. Ramesh, ma'am, please give your valuable inputs.
Excellently covered, Dr. Manjula. Just a few slight differences. What I would say that my progression, I would call any child increasing more than 0.5 diopters a year, so that I would consider as progressive myopes and consider treatment once I have documented. Even for pre-myopes, I at the present do not intervene pharmacologically. I intervene with lifestyle changes. And the advantage is that one, I introduce lifestyle changes for 6 months, so that they get to know that lifestyle change is also an intervention, and it's not just one of the things we kind of tell them, which just like you tell a diabetes, don't eat, and they'll say I never eat sugar. Yet my blood sugars are 180. So it's just like that. All children are excellent at compliance and playing outdoors and not doing any tab phone work. But so insisting on that. And the second thing is this helps me to know the rate of progression of the child. And as Manjula pointed out, that how much impact each intervention is happening, you can get to know once you know his baseline progression. So you'll know the impact, and you can take a call that the intervention you're starting off with, how impactful that is, and whether you need to, if you still have a child who's progressing significantly, whether you want to continue and add this treatment and add another, or in case of say low dose, move from 0.21 to 0.25, or else you want to kind of substitute because this intervention has had virtually no significant effect. So in that case, I would rather think of switching rather than adding a treatment to something which is not working. So why just add on or give a treatment, because I'll know the efficacy of that. So those are kind of start off this, just to start off the point I would add.
I was looking at some questions in the chat box, and there are questions about whether we should start with combined therapy because it is going to be more effective. But I think you should first document progression. It is important that all these interventions are for progression of myopia and not really a treatment for myopia. We have to be very clear on that first. So I think it's not right to start intervention from the first prescription of glass, number one. Number two, combined is like going with a sledgehammer. So I think that is also should not be encouraged as your first intervention. Yes, if it is a non-responder or despite one intervention for at least a year or more, it's not working, then you can add or you can substitute, but I think not with combined therapy straight away. And yeah, Manjula, congratulations. Very nicely done presentation.
Thanks, Sumita.
So, ma'am, about accommodation lag. So, how do we manage accommodation lag? Can LDA combine with accommodation lag or glasses?
You want me to answer or anybody?
Ma'am, you can answer.
Yes, go ahead, please.
Suppose accommodation lag is there, then you may have to, low dose atropine actually you can give, but you may have to add a bifocal or a progressive addition lens in addition, because our low dose atropine is actually only a 0.01%. I don't think so. As I told you, it does not act on the accommodative pathway to reduce your axial length progression. So starting LDA may not worsen your this thing, but if because you're going to give for the accommodation lag a glass like a bifocal or a progressive, so you cannot give the defocus glasses, isn't it? It is not possible. So you need some other modality to curb your myopia progression if it's progressing. So LDA and bifocal or a PAL will be the best kind of proposition. If anybody else has any other thoughts, can share.
Accommodative lag is not necessarily a causative factor. So it's an association. And we know that children who are, myopes have an accommodative lag because they do not have a requirement for near, so their accommodation is not so well developed. And the first time, if they wear distant correction, they are kind of, initially using their accommodation. So you need to ensure that the accommodation lag is true, or they have a subnormal accommodation and having near vision problems. Accordingly, as Manjula said, then they need treatment for the accommodative lag, which is different from your treatment for myopia. As like I said, there's no clear evidence that it is a causative factor. It's an association, but at the moment there is no causative attachment to accommodative lag. So low dose atropine very, very minutely affects anything, either whether it's pupillary size or it's near vision. So there is no contraindication to 0.01. We've seen it slightly more with 0.05, but even there we haven't had a child who had difficulty in near work or reading. I cannot offhand say that how it impacted children who had accommodative lag to start off with, because I don't think we have that data. But we didn't have any child who dropped out because of 0.05 because of near vision problems. So I don't think that is at the moment a contraindication. But yes, you should measure accommodation, range of accommodation, near vision in all children when you're doing your baseline myopia assessment, as very strongly, rightly pointed out by Manjula.
There is another question. In children with a high AC by ratio with progressive myopia, what would be the preferred method of control with the high AC by ratio?
Again, if it's very high, that's what these are all associations, as Dr. Rohit said, rather than the causative mechanism. So these are, what do I say? These are the ancillary findings which you get in a myopia progression. So if there is high AC by ratio, again, they will need bifocals for this thing, reducing the accommodative convergence for each diopter of accommodation, and you may need to give a low dose atropine for the progression. So not all children will have, but just make a documentation. Because right now in my practice, I've hardly seen any child with high AC by ratio. Accommodative lag we see now and then. But these are just things which can be, indicators for myopia progression, which you have to look into your patient when you're assessing the patient. That is why it's been portrayed in today's talk. Be it esophoria or this thing. Esophoria, if it is there, we see esophoria quite often. Then you will have to give prisms, base out prisms. And if it's an exophoria or an IDS, base-in prisms have to be incorporated. So depending on the muscle balance, you may need prisms to be incorporated in your prescription sometimes. And glasses like your DIMS and things like that, they have prism incorporation as well. Up to 3 to 4 diopters, prism diopters can be incorporated in each of the glasses.
Many have doubt regarding starting LDA or giving glasses during first visit. So even if the child is moderate myope, so shall we wait?
That has been the essential thing of this talk. At least 2 checkups, you need to document progression at 6 months interval, and then you start your therapy. I think first visit is like too much, as Dr. Sumita says. I think it's like you're overacting when it's not needed. I think that is not needed.
And also you have to think that whatever intervention, it's going to be for many years. So if you are seeing a 8-year-old, are you willing to put them on atropine for next 8 years from the first visit? I think you should document progression, and not only just document, it should be progression which needs to be intervened with. 0.25 progression is not progression. You're not going to go below that even with atropine. So you have to also look at very, very long years which our child is going to be with intervention, with even if drops are cheap, you look at the cumulative over the years, how much expense it is. So I think without documenting progression and without documenting clear, which myopia consensus panel has also put it among, which were pediatric ophthalmologists from all over India. And we all agreed that it is progression of more than 0.5 over a year, and then only you need to intervene. If child has progressed by 0.25, don't give in to parents' anxieties by adding intervention just because they are hyperventilating about glasses. I think you should reassure them that it is not much and it's not going to increase.
Lifestyle
Can I
modification.
make some, Dr. Mukesh, can I make some
Dr.
comments?
Meenakshi.
Because I've cut short a Carnatic music concert so that I can come and sit here on the panel.
Yes, ma'am.
So let me share. This is a music season in Chennai. We're all concert hopping. So let me make some points so that I've done my duty. Excellent presentation, Dr. Manjula.
Thank you.
And you covered just absolutely everything in a very methodical manner. Let me just share some thoughts which applies to anybody who is going to be treating myopia, not pediatric ophthalmologists, comprehensive ophthalmologist. So today, myopia for me takes more chair time than strabismus, more chair time than allergies, etc. Because you have to take so much history to find where you can find environmental modifications that you can insert into the child's lifestyle. Okay, who is the culprit? Where is the problem occurring? You need to get, so there's so much chair time involved today. So basically chronicle the day. When the child comes, I actually chronicle the day. What happens? When he wakes up with breakfast, is he watching phone for 30, 40 minutes so that the breakfast will go in? Like that, you have to take history for a myopia child. Okay, you have to know exactly what is going on during the whole day. Who watches the child? Is the child being watched by a grandparent where the parents are at work, which means the child is getting 2 hours of screen time because they want to keep the child quiet. So screens are going to lead to progression. So you have to actually document the day. Second thing is, I found it's not important only to find out if the parents are myopic. You have to find out how strong is the gene in the family. I've started asking, what about the grandparents? Have they been wearing glasses from childhood? What age did the parents start wearing glasses? What about the parents, the uncles and aunts? What about the first cousins? So gives you an idea of how strong is the gene, the myopia gene in that particular family. It helps you predict which child is going to progress, and gives you a you can give a roadmap to the family as to what to sort of expect if they don't start behaving themselves. The next big challenge is, we often ask question about what about outdoors? Does a child go outdoor? You impress upon them it is the sunlight. It is not the outdoor. The child will come home, finish tuition, drawing class, music class, and go out to play at 7 p.m. So it's of no use at all. And in addition, now we have, so you have to tell them that an open space sunlight, like a park or a beach, is better than what is in your apartment complex, which is better than what is in your balcony, which is better than what is in your brightly lit room. So you'll have to actually grade the amount of sunlight the child is getting to know whether the child is really getting adequate sunlight. And when they say sports, clarify whether basketball is outdoor court, indoor court, whether badminton is outdoor court, indoor court, swimming is outdoor or indoor, because that makes a big difference. They'll say, yeah, my child is in sports. So like they have done their due diligence, but no, you have to clarify what exactly is going on. And I'm sure all of us see NRI patients now, right? From the US, they will come here because US does not have many of the things we have today here in India, but they will be living in Seattle where there is no sunlight. So in such kids, you may want to be a little bit more proactive in treating. So that's one. And I just have one other comment from what Dr. Manjula said. Adolescence is generally when you slowly start tapering. But beware, our kids in during board exams, they are with their books like crazy. So you may find a rebound during the board exam. So watch them very closely. You may have to restart the low-dose atropine closer to the board exams. And I just have one important thing I want to add is, make sure that they are not using the low-dose atropine or the DIMS as a crutch while they continue with their, gadget abuse and absolute no sunlight, and we bash up, gadget. If you just ask them, does child read a lot? Only recently I realized there are kids who are avid book readers. Okay, so you find kids who are progressing, they may be reading books, and then often kids will lie down and read books, which means they take the book very close to their face. So, and then, or they'll be in drawing class where they'll be bending forward and doing some small drawings. All this counts as near work. Remember, the first many studies of myopia and near work were all about books, that we did not have this many gadgets at the time. So while we ask gadget history, we sometimes forget to ask book history these days. I think that's all I have to add. Thank you.
Very nice. Thank you. Thank you, ma'am.
Thank you, ma'am. There is another query regarding peripheral hyperopia. So, should we document peripheral hyperopia before starting the DIMS glasses, and how much hyperopia is significant to start with the DIMS glasses?
Actually, to be honest, I am not documenting peripheral hyperopic defocus because we don't have an open field AR in practice in our setup. But some of them are doing manually. I think Dr. Ramesh will be able to give insights on it better. Is Dr. Ramesh there on board?
Yeah, Manjula.
You can tell about the peripheral hyperopic defocus.
Peripheral hyperopia, I think it's one of the risk factors for progression of myopia, as we are talking about family history. When you classify them into mild, moderate, or severe progressors, if you look at that, peripheral hyperopia is one of the risk factors. It can be checked. I think Manjula showed open refractor. It costs a little bit in the sense it costs around 18 to 20 lakhs to have that instrument itself. At Teleprasad, we have developed something very simple. It's called a simplified peripheral auxiliary refractive component, where you can put it on the frame, and there is a 22 degrees nasal and temporal. So any clinic in India or in the world can have that, and then we can measure. Like we spoke about high ASB ratio, we spoke about esophoria, we spoke about accommodative lag. These are all components of myopia which can be there. Probably you can modify what's the best treatment to start in that particular patient, looking at the age of the patient and rebound phenomena and everything. But one differentiator between which treatment to start is peripheral refractive hyperopia. Most of the papers, if you look into it, most papers won't do it because that's always started with the historical thing, what is available in that country and what can be made available. Like for atom study started with atropine, right? And then slowly with the studies by the Boston group, we knew that peripheral relative hyperopia. It's not peripheral relative myopia, which is important. It's peripheral relative hyperopia. It's important. So then it's very easy to customize for you. Okay, should we go for defocus lenses or low dose atropine? Because these are the two most commonly used modalities for myopia control. So I would say it is possible, but it's just that you have to spend additional 3 or 4 minutes in estimating. Okay, do a central refraction, do a peripheral refraction, so that it gives you one more layer of decision power. It's not that absolutely it's a must, but it tells you rather than shooting in the dark, okay, I'm customizing this myopia progression treatment. But having said that, many people think give glasses or atropine and forget about behavioral therapy. Many children also say, I'm wearing glasses, everything else is muff. I can do screen time, all that. That is something we should always, stop and we should encourage. And one more thing, people start just without even knowing what is happening to the child. 0.5 myopia without even knowing the progression, either DIMS glasses or any of those glasses, and give drops. That blanket treatment is something we all should avoid. That's the whole crux, I must say. Evaluate, identify the risk factors, define progression, and then define what you want to give for that particular child and monitor. Don't give glasses and ask them to come after a year. Monitor them and then give the treatment. That's what I would say. But yeah, it is possible to do. But I know it's a behavioral change what is required because, in some of the countries, they don't even measure the axial length. Because axial length measure is not a common thing happening in myopia. It might happen in institutes and with big practices, but it's not a common thing. They just do refraction and then do it. So these things are very important, according to me, if you are managing myopia progression. Simple things, but do it consistently.
I think Ramesh has raised that very, very important point, which I think doesn't get get due importance. We are treating axial progressive myopia. That's the bottom line. Confirm that, at least at the baseline, confirm your progression to be due to axial progression. Your change in axial length on at least on one baseline and one follow-up biometry. Subsequently, you may not require it on every yearly follow-up if you don't have access to, although it always helps to document. But that is the important thing, and it is important. That is why to rule out other causes of progressive myopia like keratoconus, like a preterm child where the anterior segment may be responsible for the increase in myopia, or lenticular change or things like that. So that is the most important thing. And Ramesh pointed out about peripheral refraction. It's very good that there is these studies didn't mention, probably because it is not the underlying factor only. As Ramesh said, there are multiple factors that may be responsible and different in different children. So it's actually good news that probably only peripheral refraction is not the indication for these special spectacles, because it has been shown to work in all kinds of children who may not have peripheral hyperopia. So that's the most important thing. So currently your decision making should be, one, confirm axial progressive myopia, and I decide what treatment basically between optical and pharmacological based on the cost effectiveness or the acceptance of the parents on the glasses, and of course the compliance of the parents. I mean, are they willing to put one drop every day, both eyes at night, for a year or 2 years at least? With nuclear families, with parents being busy, it is not something so easily done. So these are things, as we're repeatedly saying, chair time, discuss, identify your child, tailor your treatment based on the economics and the acceptance of the family and the child and parents.
Rohit, I have a question for you actually, and I worry, since I sit in private practice and you see some really odd people, and sometimes there's different from in an institution. So my worry is this: I know you mentioned that you do not start intervention for pre-myopes. I worry in the future if there'll be a lawsuit saying, "Come on, all that was required was a pair of glasses, peripheral defocus glasses. You could have fitted. If you had done that, my child would not be myopic today." I worry that such a scenario will happen. What is your response? What is your thoughts?
I would say currently there is no evidence that pre-myope needs necessarily to be treated. And as I said, I compulsorily will advise lifestyle modification, which has evidence. In fact, the stronger evidence for lifestyle modification is for prevention as compared to progression. Studies are equivocal on having that much impact on progression, as they are clearly defining that there is limitation in incidence of myopia. So I would say that we are still currently on fairly firm ground if we advise the parents that we are willing to, we should, and this is an intervention. I would repeatedly say that as doctors ourselves, we should not doubt that you are intervening by lifestyle change. Dr. Meenakshi has talked so extensively. Whenever she talks, I always love to hear her when she talks on lifestyle modification, because she makes that hard-hitting point. Do not think lifestyle modification is no treatment. It's like saying that controlling blood sugar, reducing or controlling carbohydrate intake and sugar intake has no role to play. It is stupid of us to accept that. So similarly, I would say myopia, childhood myopia, is the youngest lifestyle disease that we are having, and lifestyle modification is the bottom line of treatment. So as ophthalmologists, please remember to accept this yourself so that you can hard hit the parents, the caregivers, and the children. This is, I tell every child this, every parent this, comparing it with diabetes. if you cannot treat diabetes by controlling sugar intake, you cannot treat myopia without lifestyle change. And as Dr. Meenakshi said, you need to sit with the child. Each child has a different, lifestyle and causes, and each child needs a tailor-made lifestyle modification. So do not undermine the importance, particularly in incidence.
And Rohit, thanks to you is when why I keep getting these talks on lifestyle modification. So whatever I have learned is thanks to you, your intervention. On this point, very well summarized by Rohit. I just wanted to add again one of those recent talks. I discovered that the amount of light available at the blackboard and the amount of light in the classroom where the child sits also has been shown in a couple of papers to affect progression. So if I don't know if these things are being monitored by our school system. I suspect it's not. So I think despite everything, if you find the child is still progressing while we are going in the route of starting treatment, but this is also something to explore. I increasingly feel we have a role as people who have a public health persona and a public health duty to actually engage with parents in the parent-teacher association. If we have an opportunity, especially if we have kids and my age, maybe even grandkids. I don't have any, but it gives a opportunity to engage in the parent-teacher association and speak to the parents, speak to the teachers, where they start cutting down PT period and they're all replaced with classes. So I think it's it is our duty. We are the torchbearers, and I'd be happy to sit with all of you who are here to find out something that we can take to the parents, take to the schools as a package to this kind of thing. Thank you.
There is one more query about amount of astigmatism in myop. So is there any cutoff like for this above for this astigmatism we won't be able to give drops, or we can give any amount of astigmatism with myopia?
Pure astigmatism, you should not. If it's purely an astigmatic refractive error cylinder, there is no need for any because it's going to be a corneal myopia. But then if you have an actual myopia with astigmatism, you can start with your modality. Even your defocused glasses corrects up to 4 diopters of astigmatism. So I think astigmatism is included on board. But we are looking at actual myopia. Anybody else?
I think there are no limits to astigmatism as far as the drops are concerned. And one more point I would like to make is sometimes myopia, we always look at it from the point of intervention, I am going to intervene because child has myopic, but also remember several syndromic myopias, there is actually a retinal pathology, and that's why the myopia is there. So
sure.
I think unless vision is 6/6 or 6/9, at least do not start any intervention.
Yeah, for 6/18,
even with glasses. So if you have persistently 6/18 vision after say 1 year of wearing glasses, don't start on intervention. You look for the cause for that, because it can be just a CSNB or it can be a retinal dystrophy. It is fairly common in children to just present with high myopia, fairly normal looking fundus, and only pointer or only red flag in this is myopia and subnormal vision. So unless vision is normal, or do not start intervention, because you are not serving child by anything. And I see several patients who have missed on retinal dystrophies and have been just on myopia control measures for their myopia, which has nothing to do with axial myopia. It is just a retinal dystrophy which is there. So I think we should also look at these children as comprehensively as possible, take a look at the fundus and try to explain why they have subnormal vision. A child who is moderately myope has no reason to have, at the end of 1 year of wearing glasses, to have subnormal vision. I'm not saying about -18 or -20. Those probably may not improve because there are retinal changes already. But a child who is -4 and 6/12, at the end of 6 months of wearing glasses, you need to explain why he is still 6/12. And not worry about
unilateral myopes, I think. Unilateral myopes, anisomyopias. Those are things which have to be.
Yes. So always take care of vision first and then worry about myopia as second.
So I think we have covered all queries also, and it was such a wonderful session. So I thank speaker and the panelists for this wonderful knowledge, sharing their wonderful knowledge with us. So I think we can conclude here. And the next session we have on the 8th of January on the FACO It's Simplified. So I request everyone to join that session also. And again, I thank everyone for their valuable time and sharing their valuable knowledge. Thank you. I think we can conclude the session.
Yeah.
Thank you,
Good night.
Mukesh. Thank you, Neha.
Thank you.
And excellent talk, Manjula. All the
Thanks.
best.
Thanks.
Thank you, everyone. Thank you.
Thank you. Thank you, everyone.
Thank you so much. Good night.
Good night. Good night, ma'am.